Assalamu alaikum, it's me, Dr. Muhammad Kazafi. I want to present one very important topic in my humble opinion. I recently treated one patient like this, and then I got that I should present this case, and now I want to present in front of you the medulloblastoma, cerebellum medulloblastoma, and how it behaves and what is this. So we will talk and about that. While you know that the leukemias are the most common type of the malignancy affecting the pediatric population, but the brain tumors are the most common solid tumor in this population, and the medulloblastoma is the most common malignant brain tumor in children. Medulloblastoma is the most common malignant brain tumor in the children and constituting nearly 20% of the all pediatric brain tumor. It is characterized as an embryonal neuroepithelial tumor of the cerebellum, and the surgical resection followed by the radiation and the chemotherapy are the mainstay of the therapy, and with 5-year survival rate ranging between 20 and 100%. So this wide range is multifocal owing in part to age at diagnosis and presence of the metastasis at diagnosis, subgroup variant of the medulloblastoma, and concurrent cytogenetic abnormalities include the copy number variation, and the regardless of the long-term survival, treatment-related cognitive, neurological, and endocrinological effects remain a debilitating concern, and imputes of the research for the additional therapeutic modalities. So this activity describes the evaluation and the management of the patient with medulloblastoma and highlights the role of the interprofessional team in improving the care of the affected children. Actually, I want to try to describe the causes or the reasons of the medulloblastoma, and then how we can diagnose the medulloblastoma, or I want to present how we identify the treatment consideration for the patient with the medulloblastoma, and I want to describe how enhanced coordination of its interprofessional team can lead to the more rapid recognition of the medulloblastoma and subsequent improve their evaluation. So the introduction, while leukemias are the most common type of the malignancy to afflict the pediatric population, and the brain tumors are the most common solid tumor in this age group. So the medulloblastoma is the most common malignant brain tumor in children, constituting nearly 20% of all pediatric brain tumor, and it characterized as an embryonal neuroepithelial tumor. I am repeating that the embryonal neuroepithelial tumor of the cerebellum, and this is a high-grade tumor that has a propensity to spread via cerebrospinal fluid. Within the first few years of the diagnosis, mortality approximates 15%. However, cure rate can reach as high as 60% with current therapeutic modality, and the surgical resection preceding and followed by radiation and chemotherapy in the mainstay of the therapy, and with 5-year survival rate of between 50 to 90%. So this wide range is the multifactorial owing in part to age at diagnosis and the presence of the metastasis at diagnosis, and the histological variant of the medulloblastoma regardless of the long-term survival, treatment-related cognitive, neurological, and endocrinological effects remain a, we can say, debilitating concern and inputs for search for the further therapeutic modality. Before going further, I want to show one picture here. So this is picture I want to show like that. If you consider this, the whole brain and the medulloblastoma located where? Definitely it is located in the cerebellum, and where the cerebellum, you can notice that the majority. I want to show these pictures just because of that and I took from the internet, because I tried to explain on the most cleanest picture, which because according to the YouTube policy, I cannot present the pictures which are, we can say there is a, we can say, for example, blood stained or that, then I have to restrict the audience. So that's why I am presenting these type of pictures in front of you people. So this picture also showing here, you can appreciate where is the, we can say here, this is the medulloblastoma, and this is the MRI of the sagittal of the sagittal section, and this is the axial section. Here you can see this is the tumor, the deep seated in the cerebellum area posterior to the fourth ventricle. So these are the medulloblastoma here, and I want to proceed. So regarding the etiology, there is no clear etiology for the cause of the medulloblastoma, but some studies have found link between the maternal diet and the blood or immune disorder during pregnancy. Other reports an association with viral infection, for example, the early John Cunning virus (JC) viral infection, or we can say the human cytomegalovirus. These both an infection can lead to medulloblastoma, and the medulloblastoma may have familial association and are also known to be associated with the Gorlin syndrome or Fanconi's anemia, or we can say Trocott syndrome, or we can say Lai-Ferremani syndrome. So these are the four: Gorlin syndrome, and Trocott syndrome, or we can say the Fanconi's anemia, and the Lai-Ferremani syndrome. These are four disease or disorder that can be associated with the, or because of this, or association with the medulloblastoma. Examining, if we are trying to examine the data from the surveillance or the epidemiology and the end results database from the 1973, the 2007, the annual incidence for the medulloblastoma was reported at 6 per million children. In other words, approximately 450 new pediatric cases per year, and the children aged 4 to 9 year old and had a highest incidence at the 44%, and followed by the adolescent, and which is 10 to 16 year of age at 23%, and only 12% incidence in an infant or a toddler, which we consider as 0 to 3 years old. So, according to that epidemiological report, if we think that, if we understand that it is the 4 to 9 year old people are suffering more, and 44% are people are involved, and 0 to and after that the 10 to 16 years old are later involved more, and especially 23%, and 12% are involved 0 to 3 year old people, or the infant, we can say. I beg your pardon for people word. And then the pediatric incidence was calculated to be tenfold higher than an adult incidence, and the medulloblastoma affected male 1.5 times more than female. So this is the epidemiological report which I mentioned in front of you, that you can get the idea how much the preponderance or the prevalence of this tumor in the according to the age group and the gender basis. So I want to talk a little about the pathophysiology, although thought to originate from the granular cell precursor with external germinal layer of the developing cerebellum, and the tumor growth starts in the fourth ventricle and can grow to occupy it completely, and after that the tumor is spread to the cerebellar vermis and the brain stem and seeding to the craniospinal axis. Medulloblastoma is a highly malignant tumor with propensity for the local invasion and distant metastatic spread through the subarachnoid system, that is within the brain and along the spinal cord, also known as the drop mats. So the extraneural metastasis in the pediatric medulloblastoma are an infrequent occurrence and approximately 7%. The most frequent site of the extraneural metastasis in children include bone, for example, the 78%, and the lymph node means 33%, and the liver 15%, and the lungs 11%. So the extraneural metastasis in the pediatric medulloblastoma are infrequent occurrence but approximately 7%, and the most frequent site for the extraneural metastasis in children include bones, which is 78% bones, and then lymph nodes, which is 33%, and then liver, which is 15%, and then lung, which is 11%. So average time to develop after the maximal neurosurgical resection is approximately 20 months, and the survival in these cases is dismal, and the most cases can be less than 6 months. So notably, the most common cytogenetic mutation encountered in the medulloblastoma is, we can say, the isochromosome. And the isochromosome number 17q. So the resulting from the loss of the short arm with the resultant gain of the genetic material from the long arm, and all deletion in the short arm have also been frequently reported and leading to the loss of the heterozygosity of the 11p. So interestingly, the tumor suppressor gene TP53, which is located on chromosome 17p, which is rarely mutated in medulloblastoma. Thus, the search of the putative tumor suppressor gene on chromosome 17p on the context of the medulloblastoma is ongoing. So histopathology is very important here, although which are the 5 histological subtypes encountered in the medulloblastoma include, such as the classic one, then the desmoplastic nodular, or the large cell anaplastic, or the melanotic, or we can say the medullomyoblastoma. So these are the histopathology or histopathological features of different medulloblastomas here, and I want to try to explain one by one in front of you people. And in classic medulloblastoma, sheet of the small round cell possessing a high nuclear to cytoplasmic ratio are noted, and they have a high invasive tendency and possess occasional neuroblastic differentiation, and the classic type constitute approximately 70% of the medulloblastomas. As I mentioned before, but I want to tell you again that the classic medulloblastoma or sheet of the small round cell and possess a high nuclear to cytoplasmic ratio. Means the nucleus is more and the nucleus is more than the cytoplasm is less. So they have a high invasive tendency and possess occasional neuroblastic differentiation. And the classic type constitute approximately 70% medulloblastoma. Nodules of the tumor cell displaying the neurocytic differentiation on a, we say, the collagen-rich matrix characterize the desmoplastic variant, and these tumors are the less aggressive than the classic variant and account for 15% of the medulloblastoma. So the large cell anaplastic medulloblastoma, as the designated suggests, demonstrate the feature of the anaplasia, and these features are the large tumor cell with abundant cytoplasm and pleomorphic nuclei and prominent nuclei, and these tumors are typically located in the cerebellar vermis and highly aggressive and demonstrate high mitotic and apoptotic activity with large area of necrosis. So consequently, the prognosis is especially poor with short survival time after the diagnosis, and they constitute approximately the 10% of the medulloblastoma, and the last two variants are rare and make up remaining 5% of the medulloblastoma. Before to going for the history and the physical, I want to show one picture here Oh, so this picture I want to tell you about. This is the which is showing that they are the most common malignant brain tumor in the children, and definitely headache, nausea, vomiting, dizziness, visual disturbances are very common. How he can pinch and blinching his eye and putting hand over the head, and simultaneously he is vomiting and he is going toward one side. It means he has a truncal ataxia, and the seizures and the sensory deficits. And definitely how we diagnose with the help of the MRI, and the MRI is a modality of the choice. And the tumor can compress the fourth ventricle and causing the hydrocephalus, and when then it causing the hydrocephalus and causing the pressure over the brain stem, then these kind of symptoms can appear in a lot of patients. But the majority arise in the cerebellum, and the treatment usually consists of the surgery, radiation, and the chemotherapy. So this picture actually telling a lot of things, and we can understand with the help of this picture. Even though we keep this picture in our mind, we can understand a lot of. So friends, I want to show you this picture also, because this picture also very much good to understand a lot of things regarding that. You can understand there is a, we can say, if we say there is for you can see here the cerebellar hemisphere from the granular neuron to precursor cell, and the group 3 which is originate in the vermis from the neural stem cell, and the group 4 is originate from the, we can say, the fourth ventricle from the unipolar brush cell, and WNT and originate in the dorsal brain stem from the neural progenitor cell. So this is the area you can memorize by this picture, and you can understand how important. So now I want to come to the history and the physicals. So given its origin in the cerebellum with the propensity of locally spreading into the fourth ventricle, and the patient most often present with the combination of the cerebellar sign like the clumsiness or the gait disturbance and the obstructive hydrocephalus. For example, early morning headache, nausea, vomiting, double vision, and we can say the blurry vision. So since the majority of the medulloblastoma arise in the fourth ventricle, and the obstructive hydrocephalus is the not uncommon, so that these patients may present with the emesis, headache, and the lethargy, and the time from symptom onset to the diagnosis is usually short, so usually 2 to 3 months. And almost all patients have the early sign of the elevated intracranial pressure that is associated with the headache early in the morning, and the relieved over the course of the day. And the patient with the Cushing triad usually have the impending herniation and need immediate treatment. And the tumor in the cerebellum can also lead to ataxia and the truncal untidiness, and if the brain stem is involved, it may lead to the cranial nerve palsy, and that may present as the diplopia or the hearing loss or the facial weakness and the head tilt. And the fundoscopy may show the optic pallor and the papilledema, and the paralysis of the abducens nerve may lead to an inability to abduct the eye, and the sun setting sign may be seen in some infants. So the measurement of the head circumference in infant may reveal the macrocephaly. So as I mentioned in the card, one card I show you, and you remember that a few minutes back, earlier I show you there is a given origin in the cerebellum with the proportionality of the locally spreading into the fourth ventricle. It is showing there, it is compressing the fourth ventricle in the cerebellum, and the patient most often present with the combination of the cerebellar sign like the clumsiness and the gait disturbances and the obstructive hydrocephalus, for example, the early morning headaches and the nausea, vomiting, then the double vision and the blurry vision. So since the majority of the medulloblastoma arise in the fourth ventricle and causing the obstructive hydrocephalus, it is not uncommon the patient may present with the emesis, headache, lethargy, and nausea. And time from onset to diagnosis is usually short, and usually 2 to 3 months. So almost all patients have the early sign elevated intracranial pressure that is associated with the headaches and the early in the morning and relieved over the course of the day, and the patient with the Cushing triad, which is we are telling the bradycardia, hypertension, and visual disturbances. So these usually have the impending herniation and need immediate treatment. So the tumor in the cerebellum can also lead to the ataxia, especially the truncal ataxia and truncal unsteadiness, and maybe the seizures and the sensory impairment. And if the brain stem is involved, it may lead to the cranial nerve palsy, and they present as because it compressing also the brain stem there, especially the midbrain and the pons area, and because of that, because the diplopia has happened, and the hearing loss and the facial weakness and the head tilt. So the fundoscopy may show the optic pallor and the papilledema. So the paralysis of the abducent nerve may lead to an inability to abduct the eye, and the sunsetting sign may be seen in some infant. So the measurement of the head circumference in infant may reveal the macrocephaly. So here how we can evaluation not difficult for such kind of patient, because the investigation should include the routine laboratory, include the thyroid function test as well, but the computerized tomogram of the brain may reveal a mass in the fourth ventricle, and the most medulloblastoma are contrast enhancing, and the hydrocephalus is common in most patients. So the magnetic resonance imaging is performed in all patients, as it demonstrates the anatomy better than CT scan, and MRI is often used to detect the post-surgical residual disease, and the spinal MRI is also useful for detecting the metastatic spinal lesion. And on the other hand, if I say the other tests include the audiometry prior to starting the cisplatin treatment, and the echocardiogram and the pulmonary function tests are obtained as a baseline prior to the start of the chemotherapy. So the lumbar puncture may reveal the leptomeningeal tumor spread, but despite a positive MRI, cerebrospinal fluid may be normal, and prior to the lumbar puncture, fundoscopy is done, and following surgery, lumbar puncture is delayed for at least for 2 weeks, because the surgery may have caused the tumor dissemination, leading to the we can say the false positive results. So as we know, there the treatment for the modality of choice for recognition of that tumor, it is the magnetic resonance imaging, and definitely with contrast it will show everything. And definitely if you want to see the metastatic droplets in the spinal axis, so you have to do the whole spine MRI, and which is very mandatory. And the audiometry we have to do, because an echocardiogram and the pulmonary function test definitely we have to do. And the people are doing the DSA, digital subtraction angiogram, even though to check the vascularity of that tumor, and how much it is pressing the veins, and like that people are interested in each and everything. But simultaneously we can say if we are considering, because as I mentioned, 7% of the medulloblastoma involving the other extra neural tissue, such as the brain, such as the bone, which is the 78%, and then we can say the liver and definitely lungs, because the liver is 15% and the lungs are 11%. So the CT scan of whole body definitely sometime needed to check any metastatic lesion, because the medulloblastoma is a malignant tumor. Simultaneously, I want to tell you here, but before telling anything, I want to show you one picture. Actually, this picture is when came into mind, I was thinking I should put in the lecture, because the medulloblastoma bulk transcriptions you can see there. Regarding the fourth group expression, you can see the age and the individual on the transcription continuum, and we can say in the group 2 we can see the lesser age, and there is a more age, and then isochromosome involved in the medullo. You can see in that in the type 5, type 2, or type 8, which is intratumoral heterogeneity by the methylating subtyping, and the early human cerebellar and signal and a cell transcription, which is all telling lot of things, and these pictures are by their own telling the lot of means thousands of words, and we can understand with that. This is very important picture, and it is an example for to diagnosing the with the help of the positron with the PET scan. We can say the positron emission and a tomography, and here you can see in the posterior fossa, which is yellow or the golden in color. This is the posterior, which is the suggestive for the medulloblastoma, and how much area it is involved. So all story it is telling by the positron emission tomography. The positron emission tomography is not routine, is used not routinely, but in some time it can be used where you have some suspicion and you are not confirmed with that, but you can diagnose with the help of that. That's why I mentioned in front of, because as we were doing the evaluation, so I wanted to add this. And this figure you can appreciate here with the help of this. You can see that there is the hyper intense, we can say, definitely we have to say, this is the circular round, well demarcated in T2 image, T2 weighted image, and this is the medulloblastoma. So here it is MRI, and MRI, that's why the MRI is the modality of choice. So that's why now we will go for the treatment. Yes, so treatment and the management is the current treatment modality of the medulloblastoma, combined surgical resection with the chemotherapy and the radiation, and by traditional risk satisfaction cure rate in the average risk group reached 3/4 of the patient. However, post-surgical treatment related neurologic and cognitive and the endocrinological sequelae, including the intellectual radiation and the growth hormone deficiency, or the remain a source of the morbidity in up to 80% of the survivor, and the high risk group experience up to 50% mortality due not only because of the presence of the extraneural metastasis at diagnosis, but also due to the young age of the diagnosis, which possess the significant limitation to their therapeutic option, and namely lower dose of the radiation and the chemotherapeutic agent. Because the newer subgroup classification system and have facilitated the development of more targeted therapeutic aimed, and we can say this is the disparating and a single transduction pathway critical to the phenotypic transformation, and these are currently under clinical investigation. Actually, I want to discuss here the SHH subgroup. SHH pathway is what I just want to mention. This pathway is activated by the binding of the sonic hedgehog to its receptor, and the PASD, or we can say the PTCH1, and which activate the downstream signaling via key mediator, and the most widely studied targeted therapeutic agent today are the SMO inhibitor, or the we can say the cyclopim, or we can say the vismodbig, or ceridibig, or we can say sonidegib. So these all digibs which I mentioned in front of you, especially the sonidegib and vismodegib, are we can say they are currently in phase 2 clinical trial in patient with the relapsed SHH subgroup medulloblastoma. As I mentioned here, SHH medulloblastoma. Now I am going to the WNT, which is the subgroup, and simultaneously I want to show you here picture which you can understand. I'm really wanted to show this picture. Here you can appreciate there is a, if you see there is an apoptosa, encircled tumor with the red marking, and then above you can see the histology which is showing the desmo, which is the classic one, which is the 70%, and the desmoplastic, which is 15%, the LCA 10%, and the others is the 5%. If we consider regarding the gender, there definitely you can see the male predominance is more than female, and simultaneously you can appreciate here there is a Thompson B cool A, and we can say the Northcote WNT. We can say the WNT and is about 10%. This is the molecular distribution. SHH is a 30% in Thompson cool, and the Northcote, which is sold the SHH and is a 30%, and the 3% the group 3 is 25%, and the group 4 is a 35%. So these all four are in a distribution in front of you, so you can understand these are the subgroups of the medulloblastoma, and you are now familiarized with that and you can understand very well. In this picture, there is a proposed guideline, and the proposed guideline for the medulloblastoma genetic means the counseling and testing, and WNT, as I told you, the absence of the somatic and a CTNNB1 mutation type for APC. SHH is a test for the PT, and a CH, which is as I told you, TP153 and or the BRCA. 2 involved, and the group 3, which is the family history of the BRCA associated cancer test, and the group 4 also the same, the family and history for the BRCA associated cancer test for the BRCA2 and the PALB2. So these are the proposed guidelines for the medulloblastoma genetic counseling and the testing prior to happening that. So this is some addition I want to add in in this lecture. This picture actually telling a lot of things in front of you, as I started with that picture, and then beside that this is a treatment, surgical treatment, how we are exposing that and how we are looking that and how we are addressing these kind of tumors. So here, as you know, there is a differential diagnosis when we are looking, especially the medulloblastoma. Definitely the differential diagnoses are coming in our mind, such as the choroid plexus carcinoma, or maybe ependymoma or the teratoma. These three we cannot exclude: the choroid plexus carcinoma, ependymoma, and as I mentioned before, the teratoma. But the surgical oncology, and I show the picture just before you, the surgery aims to excise as much as tumor safely, possibly to relieve the obstruction of the CSF. However, should be taken during surgery, as the tumor is friable and can quickly disseminate, and following surgery more than 40% of the patients have the residual neurological deficit, and besides cerebellar dysfunction, other may develop mutism or the cranial nerve palsy and the hemiparesis, and some symptoms do resolve with time, but extensive rehabilitation is required, and at least 50% will have a permanent deficit, and in most patients a ventriculoperitoneal shunt is necessary for the relief of the hydrocephalus, and some patient may obtain a benefit from the endoscopic third ventriculostomy. So besides central venous access for the medication, and Ommaya reservoir for the chemotherapy is often used, and however all these procedures have risk and technical complications are common. So here you should know the ventriculoperitoneal shunt is necessary for the relieving of the hydrocephalus, and most of these patients are presenting with the hydrocephalus, and some patients may obtain a benefit from this endoscopic or for example ETV or EDV and EVD. It's up to you. For example, an endoscopic third ventriculostomy, or for example the external ventricular drain if you are going for the second surgery. But in my humble opinion, VP shunt is better than the better than the EVD in this way, because the patient need for a longer period of time. But few people are believing in that. When they want to give the medication, they are putting the Ommaya reservoir for the chemotherapy often used, and however all these procedures have risk and the technical complications are common. So radiation oncology, we can say the radiation therapy is often used for the local control and the management of the micrometastatic disease, and the radiation is administered to the, we can say, the craniospinal axis to minimize the response. It should be given within 4 weeks after the surgery, and reducing the dose of the radiation to minimize the complication is associated with higher relapsing rate and a poor outcome for those who relapse. The prognosis is dismal. So at this stage, the additional radiation may not help. And you know that and if we think about the breeding, as I mentioned before, I multiple times I took the name for the WNT and everything, but I want to present here like that. Regarding the staging, the patient with the medulloblastoma were traditionally stratified into the average risk to the high risk group, and based on the three primary characteristics according to the age and the extent of the residual tumor post-op and the degree of dissemination at the time of the diagnosis. Patients who were at least 3 years old at the diagnosis and had almost 1.5 centimeters for the post-operative residual disease by MRI, and those have had no extra neural we can say metastasis, were categorized as the average risk, and the rest are high risk. So only those are an average risk which they have no extra neural metastasis, and those have the only 1.5 centimeter post-operative residual, and we can say the patient who are we can say means at least 3 year old at the diagnosis. So otherwise all are high risk, and you know that this traditional risk and stratification discontinued the influence of the tumor histology or the tumor behavior and the impact on the patient's prognosis. So the recent transcriptional profiling studies derived from the microarray data of the large number of the patients with the medulloblastoma reveal the cluster of the patient with similar transcription, and we can say the proteomose, or we can say the cytogenetic signature involving the unique signal transduction pathway, and this has led to currently accepted classification system of the medulloblastoma in 4 primary subgroups. And you know that the SHH, we can say the sonic hedgehog, which is called the SHH, or WNT, we can say the wingless, or the non-SHH or non-WNT, which is called the group 3, and the non-SHH or non-WNT are the group 4. So it is simple to understand. I have to tell you earlier the SHH is a sonic hedgehog, and pronouns for the SHH and or the sonic hedgehog, or we can say WNT, the wingless. So these are the four classes or the 4 stages for this tumor. However, the system has not only augment and progenication, but also the facilitate had the development of the novel therapeutic option. That said, the field of the medulloblastoma is ever enveloping, and there may be many as 12 subtypes of the medulloblastoma that cluster with the high fidelity. And you know, they are using a combination of the molecular profiling and the histology and the WHO, and presenting divided medulloblastoma into the 5 subtypes, which is the WNT, which is activated with the classic histology, then SHH and activated with the wild type TP53 with classic or desmoplastic, nodular or large cell anaplastic histology, and SHH and activated in a TP53 with classic and the large cell anaplastic histopathology, and the non-WNT, non-SHH group 3, which is classic and the large cell anaplastic histopathology, and non-WNT or non-SH group and for with classic, or we can say the large cell anaplastic histology. And the prognosis I must share with you. The outcome depend upon the several factors, including the age, stage, and the extent of the residual disease after the surgery and the response to the treatment. And definitely WNT subtype have a good outcome, whereas those with the MYC and MYC implication have poor outcome. So even after success treatment, many patients are left with the permanent residual neurological or cognitive deficits. So the children have difficulty with the learning, and there is a growth impairment. In addition, deficiency of the gonadotropin and the thyroid hormone are common, and the common reason for these complications are craniospinal radiation. The 5-year survival rate or survivor for those with the average risk disease is 85%, as long as there is no significant residual disease and no evidence of the spread. In a high risk group, the 5-year survival is then less than 40%, and in children less than 3-year survival rate from the 30 to 70%, and children with the metastatic disease do poor, whereas those with the SSH or we can say WNT activated lesion have better survival. Transcriptional and methylation profiling data coupled with the cytogenetic aberration, or we can say the copy number variation, and the patient outcome has helped subclassify medulloblastoma is as many as 12 subtypes and 2 WNT, 4 SSH, 3 group 3 and 3 group 4. So the highest survival rate have been consistently seen for the WNT group, which is the 97 to 100% for the 5-year, and the SHH subgroup remain intermediate with the 5-year overall survival rate between the 70% to 88%, and the non-SHH WNT subgroup have been thought to have the worst prognosis, though the group 4 have tend to do better, and the group 4 medulloblastoma has 65 to 85% 5-year overall survival, while the group 3 medulloblastoma have a dismal rate between the 40% to 65% 5-year overall survival with the MYC amplification, and we can say the portending with the poorest outcome. Here the complication definitely, you can understand with the kind of the disease, you can understand how this is maybe, but definitely I want to present a few complications such as the headache, emesis, ataxia, especially the truncal ataxia, posterior fossa syndrome, and the shunt infection malfunctions, bleeding, hemiparesis, neurocognitive impairment, somnolence syndrome, radiation necrosis, on ototoxicity, or we can say the secondary malignancies, chemotherapy associated complication. What we say to the patient family actually, or the patient, we can say the patient are more often parent of the patient and should be educated on the prognosis for the disease, and the proper consent should be taken, including all the risk given to the critical location of the tumor before proceeding with any type of surgical intervention. And the diagnosis and the management of the medulloblastoma are best done by an interprofessional team that consists of the pediatrician, neurologist, neurosurgeon, oncologist, radiation therapist, and we can say the specialty trained nurses. All are very, very important factor for the treatment of such patient. Before to end this lecture, I want to show one case for the analogy, for the understanding will be enhanced for the listener and for who want to understand this topic. Actually, I have a 4-year-old girl arrived in the emergency room with the history of the nausea and the emesis for the past 2 months, and her pediatrician had initially thought for the nausea and the emesis was as a result of the aggravated gastroesophageal reflux disease GERD, which was in her family history. However, over the past 2 weeks, she has had the more prominent gait ataxia, and she had never complained of the headaches. So the past medical history GERD definitely was there, but on examination, patient was alert and oriented to self situation and the location, and the cranial nerves such as the 2nd to the 12th cranial nerve were intact all, and no sunsetting sign for her eyes, or we can say the strength 5/5 throughout, and the sensation to the light touch and the 2-point discrimination was normal throughout, and the coordination revealed the bilateral dysmetria and the mild ataxia on the tandem straight line gait and examination. This was the positive finding apart from the emesis and the and the nausea. So here I want to present like that. Now the question is arise here, and for us that what kind of imaging I did. Definitely, I did the CT scan, brain with contrast, and CT scan, MRI scan with contrast, and it shows the first of all in CT scan it shows there's a large heterogeneous mass in the post fossa and centrally located with area of the calcification with predominantly solid appearance with some cystic areas, and this lead to the obstructive hydrocephalus with the dilatation of the lateral and the third ventricle, and that or we can say the transependymal flow of the CSF and the basal cistern and the fourth ventricle are affected. And it shows there the large heterogeneous in the MRI. In the MRI, we can see there is a enhancing T2 hyperintense T1 hypointense cystic mass with the restricted diffusion occupying means entirely of the fourth ventricle and causing obstructive hydrocephalus with the transependymal flow and the inferior herniation of the cerebellar tonsil. So the multiple cerebellar satellite lesions are we can say the compatible with the metastasis, and note that the absence of the tumor component below the foramen magnum, and which would also be consistent with the ependymoma. The MRI feature of the medulloblastoma are diverse, but generally include the we can say diffusion weighted image and we can say the positivity and the heterogeneous and or homogeneous enhancement, and the medulloblastoma because of its location can be associated with the obstructive hydrocephalus, and in up to 10 to 15% of case can have a leptomeningeal dissemination. So these were all details were there in the CT scan and MRI which I mentioned for you, and you when we have to talk like that. We have to talk like that. There's a large, if you are seeing this is the MRI which is suggestive for the post fossa tumor, so you have to explain on the first of all like that. You have to explain the heterogeneously enhancing T2 weighted hyperintense or the T1 hypointense cystic mass that the restricted diffusion or we can say occupied entirely of the fourth ventricle and causing the obstructive hydrocephalus with transependymal flow, and we can say the inferior herniation of the cerebellar tonsil and the multiple cerebellar satellite lesions are compatible with the metastasis, and note that the absence of the tumor component below the foramen magnum which would also be consistent with the ependymoma, but not here. So the MRI feature of the medulloblastoma are diverse, but generally include the diffusion weighted positivity and the heterogeneous and the homogeneous enhancement, and the medulloblastoma because of its location can be associated with hydrocephalus and obstructive, especially in up to 10 to 15% of the cases, and can have the leptomeningeal dissemination. And you should mention this because if you can see, then definitely you have mentioned it. Other than this, you have to do the full laboratory examination. For example, the routine laboratory analysis, for example, the CSF, or we can say the glucose, protein, and the cytology, and generally obtain 7 days, or we can say the post-operatively via a lumbar puncture and the imaging. We can say and we can say the MRI entire brain and spine with and without contrast, and to check for the drop mats, and definitely you have to. And for example, the consultant, for example, here we can say if ventriculostomy need to be placed, so ICU admission is also necessary to the frequency for the neurochecks, and which is every hour in the immediate pre and the post operative period. So the neuro-oncology to initiate the we can say the team directed approach for care, and we can say that we can do the coordinate care pre and the post operatively by the complementary modalities of the treatment here. So, and these all are the actions required by us here. And definitely I mentioned a lot of things, but I want to mention here for the knowledge. This slide came in my mind, and I want to present like that, such as for example, if we can say the Chang's staging of the medulloblastoma with the metastatic stage, and which is also called the M system, and which is the Cheng's staging of the medulloblastoma with metastatic stage. I want to mention here because it's very, very important to understand, and definitely it is very important to know regarding the medulloblastoma. And here I want to mention like that the tumor less than 3 centimeter in diameter, or tumor more than 3 centimeter in diameter. If the tumor is less than 3 centimeter in diameter, it will consider the T1, and the tumor more than 3 centimeter in the diameter, it will consider the T2. And when the T3A, we are telling the tumor more than 3 centimeter diameter but with extension, it is called the T3A. T3B is definitely the tumor more than 3 centimeter in diameter but with equivocal extension into the brain stem. So equivocal extension to the brain stem, then it will consider there is a 3 and a B, T3B. When we are going for the T4, then the tumor more than 3 centimeter in the diameter with extension past the aqueduct of the sylvius and down and apart the foramen magnum or beyond the posterior fossa. When it is anything going beyond the posterior fossa and definitely tumor is more than 3 centimeter, then definitely you can say that the T4. And you know, and when we are telling there is when we are talking about only especially M classification or M system, here M0 means no evidence of the subarachnoid or hematogenous metastasis, so we say the M0. When we say M1, then tumor cell founded in cerebrospinal fluid. It means you can do this M system when you are taking the CSF associated with the lesion, when you know that there is a lesion. So there is no evidence of the cerebellum or we say the hematogenous metastasis, then M0. And then when you say there the tumor cells found in the cerebrospinal fluid, this is the M1. And when you see the intracranial tumor beyond and a primary side, apart from the primary side, when you find that, then you consider the M2. And when there is a gross nodular seeding in the spiral subarachnoid space, which is called the M3, and we can say the metastasis outside the cerebrospinal axis, especially for example in the bone marrow or bone, then you are telling the M4. So and definitely the exact pathophysiology nobody knows, and it is not certainly, but definitely I can say some idea about the pathophysiology which I mentioned before, but I want to tell you regarding regarding the certainty or somehow which we can say the medulloblastoma is the most common malignant tumor during childhood, while the incidence of the pediatric brain tumor is about between the 5 per 100,000 person per year, and the medulloblastoma is the most common malignant type, and the medulloblastoma is derived from the cells of the external granular and a cell layer and can be classified into 4 molecular subgroups based on the gene expressed data, which I told you, the wingless, which is called the WNT, and the sonic hedgehog, which is called the SHH, and the group C and the group D, or we can say the group 3 or group 4. Then the medulloblastoma is a WHO and a grade 4 tumor, and it is histologically composed of the classic large cell anaplastic and the nodular desmoplastic feature, and the nodular desmoplastic are, we can say, generally SHH driver tumor and are seen in both young and the old patient in the bimodal age disturbances. And the Chang staging of the medulloblastoma with regard to the metastatic stage M system is summarized. So the standard risk medulloblastoma previously defined as more than 3 years of age, classic pathology less than 1.5 centimeter, 1.5 centimeter of residual, and no dissemination at the diagnosis. So with associated with the survival of the 85 to 90%, and with the standard chemotherapy and radiation therapy. However, we now know that the molecular underpinning of the tumor is described above, and or what are determining survival, but the treatment for both now diagnosed and recurrent medulloblastoma is not uniform and is depend on the patient age. So If we are considering the treatment option, definitely the medical one I want to discuss first. The decathlon pre-operatively can improve the patient nausea and vomiting, and and important to remember the GI prophylaxis and the glucose checking during the administration of the steroid. And after that, the biopsy is coming in my mind, because the biopsy, definitely you know that the biopsy not necessary as a full surgery indicated, or we can say the once craniotomy and the exposure performed, then the resection of mass should be attempted, given that an extent of the resection is all are important and variable in determining the subsequent treatment and outcome. Adjuvant therapy, as I mentioned here, the radiation and the chemotherapy are very important, and you know that the craniospinal radiation or adjuvant chemotherapy are the therapy of the choice for the patient older than the 3 years, and alternative treatment strategy are currently being used to delay radiation therapy if children younger than the 5 years, due to the associated neurocognitive effects. So additionally, new appearances are being used to risk activity and patient, and we can say the based on the molecular subgroup. So you know the cranial radiation can also be utilized as a necessary after surgical resection, and any metastasis, or we can say the remaining tumor in the resection and cavity that is not amenable to for the further surgery, or we can say the photon and the proton beam and irradiation therapy are used to use the treatment of the childhood medulloblastoma. I try to explain you here, but I want to tell you that with the surgical, we have the options such as the external ventricular drain is indicated, then posterior fossa craniotomy for the resection of the tumor, and we can say that they are the consideration of the second look surgery if more than 1.5 centimeter noted in the post-operative imaging. So here I want to tell you little bit in detail for the surgical technique, and it is very important. As a neurosurgeon, we must know that surgical technique, the head of the bed is rotated 180 degree away from the anesthesia team, and the patient head is placed in the Mayfield head holder at a, we can say, the height appropriately for the size and the age of the patient. All appropriate pressure points should be padded as the patient is placed in a 3/4 lateral position, and it is our preference to place a majority of patient with the right side of the body facing upward, and the tumor and a lateralization into the gutter or within the fourth ventricle chamber may modify the need to place the patient left side up, and the patient head is significantly flexed and then angled in 30 to 45 degrees regard to the floor, and we attempt to keep the basis of the Mayfield pin head holder parallel with the floor, and here we attempt to keep the base of the Mayfield pin head holder parallel with the floor, so as the facilitate the utilization of the Mayfield base retraction system or stereotactic registration, and should be performed, and the good accuracy assured at this time. And few people are doing the endoscope. Endoscope are usually used with the help of image guided system, and when we are doing with the in that position the Mayfield, it will helpful for the endoscopic procedure. When we are doing, a lot of people are doing the endoscope, creating the magic in that regard. They are the least invasive, or we can say they're the least retraction and giving the good. Definitely there is a learning curve there behind that, and definitely the expertise and with the instruments all are very important. But if there is a modality is there, if their option is there, we cannot deny this and we cannot exclude that. Definitely we have to tell to the people. As you know, the Colorado up monopolar and we can say the quadri, Colorado up monopolar quadri is used in the cutting mode to make the initial scalp incision to the depth of the approximately 1 millimeter, and the Colorado tip cautery is then used to take the we can say the incision down to the underlying bone in coagulation mode, and the cerebellar and a self-retaining retractor are then placed, and we can say the operating microscope brought into the field, and we performed and we performed a C1 laminectomy on the case, and utilizing the craniotomes and to maximize the angle of the axis and into the fourth ventricle burr hole placement, and followed by the use of the Ronger's forceps is also a variable technique, but the suboccipital craniotomy should be performed using we can say the craniotome running from the foramen magnum superiorly and ending inferiorly to the inion, and likely to end the location for the trochanter. And in our experience, the height of the craniotome or the craniotomy is not as important as maximizing the width at the foramen magnum and above. So it should be noted that this approach will open the cisterna magna and maximizes one view of the fourth ventricular chamber above, and it should be and it should not be important to maximize the width or the foramen magnum as above. And it should be noted that approach will open the cisterna magna and maximize the one view of the fourth ventricle chamber and lateral gutter, and allowing for the visualization up to the aqueduct. And this approach additionally minimizes the retraction and the resection of the cerebellar vermis, and minimize the potential for the post-operative mutism. And the dura should be opened sharply with the 11 blade and scalpel, and in the Y configuration or inverted Y configuration, and the dural leaflet and should be retracted and sutured with the nylon or Neurolon, and then the cerebellar hemisphere should be dissected in the midline, and the tumor is usually immediately encountered self-retaining retractor and a blade, and then be placed on to elevate the inferior edge of the cerebellar hemisphere, and the dissection of the tumor and using suction and the bipolar cautery and can be performed. And we prepare to use the variable action such as a Fukushima type suction or these cases, and care should be taken to maintain hemostasis while detaching the a small feeding vessel, which the microcisor from the tumor periphery, and the tumor should be biopsied. Biopsy should be taken, and then the biopsy should be taken, and at the point the specimen sent for the frozen section, and then the permanent also examination by the neuropathologist, or we can say the neurohistopathologist here. So the debulking. Regarding the debulking of the tumor can be performed using the surgical microscissors and the biopsy forceps and the ultrasonic aspirator, and the floor of the fourth ventricle can be encountered at any point during surgery, and the most often when the majority of the tumor resected, and it is our preference to identify the floor very early in our resection and protect it when the cotton surgical paddies and the floor may be smooth or irregular, and if it has been invaded by tumor, it is rare to find the tumor invasion of the floor at the time of the initial surgery. Its subsequent surgeries should tumor invasion of the floor be noted, but the consideration of the anatomy and potential we can say there is a potential complication should be considered prior to the we can say there is a progressing to the resection. So attention can be turned laterally to the gutter to confirm the absence of any residual tumor, and the lateral gutter will be frequently harbor residual tumor even if it is not apparent on the pre-operative contrast enhanced imaging studies. So additionally evaluating tumor planes and below the retractor blades and should be performed at this time. So once a resection is completed, irrigation of the tumor resection cavity with the copious amount of the irrigant, and it is followed by the lining and a lining or the resection cavity with the Surgicel and a fibrillar, or we can say the maximized hemostat prior to the closing to the dura, and wait for there is a hemostasis has been secured appropriately or not. If not, then you have to secure the hemostasis as much as possible. Definitely it is not promisable and it is not easy because we don't know where the tumor has been started, but the dural graft and the fibrin glue can be used to augment, and for the and duroplasty can be done, and the bone flap should be placed and using the absorbable or the non-absorbable, and we can say the plate and the screws, and we can say the paraspinal muscles and the galea should be closed tightly, or we can say the watertight is a proper word for that. And it was instructed by the lot of many surgeons, and they are telling by their experience here. So, as you know, in the usual fashion with the vicral and then skin closed with either with the permanent suture for a subcuticular monoacral suture and followed by the skin glue based on the surgeon's preference, and the patient head should be taken out of the Mayfield and the head holder at this time, and the sterile dressing has been applied. And the complication avoidance and the management, the few golden points I want to share with you in my humble opinion. Of importance in children, intraoperative blood loss should be controlled and monitored closely with the careful attention to hemostasis throughout the procedure, and usually tumor ooze and bleeding well decrease as more tumor is resected, and as was previously noted, the careful examination of the gutter to avoid the residual tumor is also important, and avoiding injury to the floor of the fourth ventricle is also of the key importance, and injury for the facial caliculi or calculus can result in the permanent injury to either the unilateral or bilateral, and we can say the the seventh cranial nerve, and which is seventh cranial nerve function may be impaired, or additionally such injuries can result in the paresis or the plasia, and the significant injury result in aberrant extraocular movement can occur from the injury to the MLF or a PPRF, and be very aware that manipulation of the tumor causes retraction on the floor when invasion definitely is present. So the aggressive Vermean manipulation and the resection should be avoided to minimize the incidence of the post-operative mutism. Obviously, pica branch, posterior inferior cerebellar artery, and can be in a close proximity, and the strict attention should be paid to close the entire either a primary watertight closure or a graft, and the dural fibrin glue is needed, and minimize post-operative CSF leak. Additionally, the skin can be closed with the absorbable suture such as the monocrylls and the chromatic, or covered with the, we can say, the derma board. However, as previously noted, if CSF leakage is concerned, then permanent suture such as the proline or the nylon should be used, and the temporary ventriculostomy placement is often helpful for the large tumor but must be judiciously used as so to prevent the upward herniation. So this all I just want to try to present you the medulloblastoma in front of you. I try to be, it should be some interesting for you, and it should not be unnecessarily lengthy, but definitely these topics require some definitely details, and I wanted to present in front of you. I hope you will like it. If you like it, please subscribe, share, and support us. Thank you so much. See you in a new lecture.